What will healthcare look like in the near future?
Our guests on Health Talk will discuss the major trends in healthcare today that will affect its future. Stay tuned for a very interesting segment.
We're up next. Hello, I'm Dr. Andrea Peterson.
And I'm Dr. Eric Mazur. Joining us are Dr. Robert Carr. Dr. Carr is the Vice President of Clinical Transformation at the Western Connecticut Medical Group, and Rowena Bergmans, Vice President of Clinical Integration and Population Health.
Welcome.
Thank you. Thank you for having us.
So today we're talking about population health and sort of the changes in the way we're thinking about managing our population. I think in the old days it was the doctor-patient, and that was not only at the center of the healthcare system, but that was the healthcare system largely. It's really changing now, isn't it, Rowena?
It certainly is. I think that historically we really didn't segment populations either. A patient was a patient was a patient. And we had the same types of services that we directed to those individuals. Now, as the dollar is shrinking and we know that there are different populations with different needs, we're moving forward with understanding how do we effectively manage specific populations so that the quality is better, more efficient at lower cost, because we know that you can't spend $3 trillion a year on healthcare and have it be sustainable.
But I think it's important to point out that even though it's the shrinking dollars that in certain ways are driving this, the old model really wasn't working very well. Even though we were spending tons and tons of money, we have mothers without prenatal care, we have children who aren't vaccinated, we have older people that aren't screened for cancer. So it's not like we were doing a great job with the old model.
Well, that's absolutely right. Now I have to say, if you needed a specialty surgery, there's nowhere else in the world that I would want to have that specialty surgery done. But if you look at the health of a population, you look at indicators like infant mortality, preventative services, access to care, we were pretty much rated 40th internationally. So we really did struggle with that, yet we spend over 2.5 times.
I'm just going to say that per capita we spend more than twice of any other industrialized country in the world.
That's correct. That's correct. And our outcomes, and even within the United States, outcomes are very different depending on where you are. Right. So there are towns and cities outside of Ohio, in Ohio, that the infant mortality rate is higher there than it is in the Gaza Strip. Right. So it just depends on where you are in this country. There may be very specific needs and focus on those populations.
So what were we doing wrong, Bob?
Well, a lot of it was, as Rowena mentioned, not getting the right care to the right place. We were kind of in a one-size-fits-all model where we were providing the same care to every population, every patient. We weren't saying, these are some really sick patients that need a high level of care. This is a healthier group of patients that may need a different kind of care provided by in a different setting, so that we're able to provide those really high-tech, expensive services where they're needed, but we're not trying to do that across with everyone. And part of it is the...
You're not saying that those, if somebody doesn't need a high-tech service, they won't get it, though?
No, absolutely not. No, what we're saying is that you have some patients always in a population who need a lot of attention and a lot more high-level services, expensive services, but we can't necessarily. We don't need to provide those services to most of the patients. So we have to figure out who are the patients that are really going to benefit from these services, who are the patients that really need them, and provide them at the right place at the right time, so that when patients come in, we can make an assessment of what exactly is it that this patient needs to manage their illnesses, but also to stay healthy and prevent new diseases from coming across. And that's really what population health is founded on, is being able to look at your whole population and be able to take care of them, whether they're in front of you or not. So that, some of the care I provide for you might be over the phone, it might be by email. You might not necessarily have to come in and see me every time if you're very healthy, and it might be more convenient for you not to do that. But other patients need to be seen very frequently, maybe every month or even every week. And so being able to kind of figure out what is the level of care that this person needs in order to stay healthy and manage their illnesses and be sure to be able to provide that. That's what we mean by kind of stratifying the risk.
So Rowena, that sounds like, though, a huge undertaking and very complicated.
Cost.
It is additional cost. It is a huge undertaking. I think the interesting thing is, to your point, Dr. Mazur, high-tech imaging, high-tech services, those are well reimbursed, right? If you think about primary care, behavioral health services, addressing underlying psychosocial issues, historically
drug and alcohol rehab.
Yeah, those are not well reimbursed, right? So you gravitate to things that pay you better. So we haven't invested a lot of money in the infrastructure and the underlying foundational programs that really keep people well and healthy, and it really does spread into the community. So when we think about managing populations, it's not just in a clinical setting. You think about what's happening in the communities where they live, and are we addressing underlying psychosocial and social determinants? So that's, I think, the foundational element of where we begin.
Can you give our viewers some real-life examples of what's being done to think about the health of a population, to kind of make this more concrete, more
the health
real?
Of the community.
Well, there's very successful models within our own network. The community care team is one of them, where you have individuals who are frequently the emergency department, mostly for psychosocial issues, behavioral health issues, and
which is very expensive for the system.
Very, very expensive, and it's not effective, right?
To have them coming back and forth to the emergency room.
And it doesn't help the
you mean.
patient, right? Because emergency services is not where you're going to manage chronic conditions. So we've been able to convene a group of stakeholders, everything from the soup kitchen to homeless shelters, to primary care, to the federally qualified health centers and primary care physicians, to really put care plans around these individuals which address all these underlying issues. And what we're seeing is a reduction in emergency room visits. We're seeing people housed and their overall health improving. And again, if you are homeless, if you have food insecurity, et cetera, domestic violence, you're not worried about your hemoglobin A1C, right?
Which is a diabetes.
Which is a diabetes measure. You're really worried about safety. It's really around Maslow's hierarchy of needs. You got to take care of sort of this basic level of functioning before you can.
Well, it's really a melding of what we know about medicine into more of a social responsibility that we have to care for our fellow human being. I mean, I heard about, I guess, one guy, and I don't remember the details at all, but he was he's homeless in the emergency room every other week, and somebody found him a subsidized apartment.
That's
and
correct.
And there was his utilization fell by dramatically,
exactly
and the cost of that apartment to the system was less than the cost of the emergency room visits.
But unfortunately, and Hawaii has done this, where their Medicaid is actually paying for housing, because they realize that as well, that if you pay for housing, you're going to decrease the amount of services that are being provided on the physical health side.
But it's also, you alluded to it, at the high end, we're providing a lot of very expensive services. Cardiac stents, where we're learning they may not be as beneficial in all patients that we were putting them in, or some of the imaging that we do, the back imaging that is, or back surgery. So maybe you could say a few words about that too, because as we accumulate evidence, a lot of this high-tech stuff that we're doing has been shown to be non-beneficial.
Well, we often, when you're driving on the highway, you often see signs for these hospitals that talk about their great cardiac intervention programs. And what we always say from a primary care standpoint is we'd much rather advertise that our primary care is so good here that no one needs stents. And that's really, I think, what you're kind of getting to.
And that can be, I won't say it can be achieved uniformly, but from a medical standpoint, if you're screening somebody for diet and exercise, and with some of the drugs, the statin drugs that we have available, you can have a major reduction in cardiac events.
You can.
And stopping smoking. Let's leave it.
And that is one of the things that we are really doing with data in population health, is we're helping to identify patients who may be falling through the cracks. So, for example, we may be able to find patients who we know are diabetic but haven't been seen for a while in the office, and we're able to proactively reach out to them and get them in. Prior to really having data like we have now, most physicians probably wouldn't even be able to tell you how many diabetics they had in their practice. Where now we know exactly who they are, we know what kind of control they're in, we know the ones that are controlled, uncontrolled, we know who's been in and been following up with their visits, who's filling their prescriptions and who's not. And we're able to get ahead of that and be able to really reach out to them and prevent problems before they happen, so that these expensive procedures down the road may not be necessary because the patients have better managed their disease early on.
How about health systems, Rowena? How do they fit in with this idea of population health?
It's a difficult transition, right? Because if historically, as a health system, you're getting paid on these more expensive services and you're doing a really good job of keeping people healthy in the community, there's not as much need for those services in the hospitals.
So you're cutting your own throat in certain ways.
Well, yes, there's a procedure for that. But what you really want to
You want to
think
make
about...
sure it's complete.
Okay,
So
excellent.
you're not in the
Thank
ICU
you.
for too long.
I'm not a medical person. Thank you. Again, though, if you are the manager of a population, right? If you're a system that has everything from home-based services, primary care, preventative services through the entire continuum to post-acute care, you manage people where they need to be managed. So as a healthcare system, and you become responsible for that population, and you have all of these services available to you, you'll do just fine.
How about the role of government or not in this situation? I don't want to get into politics as much as I think it can be fairly said that the economics are such that this is going to happen whether the government does this or whether this is innovation at a private level, but it still requires a fairly large size, I would think.
Regardless if you're a Republican or a Democrat, everyone realizes that the cost of providing care is unsustainable. Right? We spend over $3 trillion. We have an aging population. Medicare beneficiaries tend to use services 3 to 1 to, say, someone who's younger. So we know that we are on a trajectory that we can't sustain. So we're all trying to figure out, people have their different plans, but we're all trying to figure out how do we deliver care more efficiently with better quality. And at the end of the day, you want to keep people healthy and in their homes.
And a lot of the change that's happening is traditionally we've paid for volume. Mm-hmm. The more patients that you see, the more you charge, the more you get paid, the more money you make. And that is very much shifting now to looking at outcomes. How good of a job are you doing with your patients? How well controlled is their diabetes? What percentage of your patients have been appropriately immunized?
Between community health improvement and population health improvement? Or are they really part of
There's
the parcel?
There's a lot of overlap. I think when you think about community health improvement, you're really understanding the needs of your community. So one of the efforts all hospitals undertake is a community health needs assessment, and then they need to put in a community health improvement plan. And that's looking at everything from obesity, chronic disease, behavioral health issues, access to care. So there are really foundational underlying pinnings both in the school systems, faith-based organizations that come together that really identify the needs of the community, where the health system is a player in that.
But it's interesting that no matter which community you go into, the singular needs identified are usually pretty much the same. As you said,
Absolutely.
Behavioral health, drug and alcohol, obesity, smoking maybe less so, but those are sort of across-the-board issues that we have.
We know that as a nation we struggle with mental health, behavioral health services. We know in Connecticut we have a shortage, like in most states, of behavioral health providers. We know in Fairfield County where there's a lot of behavioral health providers that just take cash. They don't even take private insurance. So we really do struggle. It doesn't matter if you're someone on a lower socioeconomic scale or a child in school or someone who's wealthy. This is a disease that hits everyone. It's not specific to socioeconomic status.
One of the most exciting things to me, and we have just a little over a minute left, is not only does it sound like it's the healthcare system participating in the community, but reaching out for the community around to participate in the healthcare system.
That's correct.
To help people be healthy. Maybe you can say a little bit more about
correct.
that.
I mean, so historically, when we think about healthcare, we do think more of the traditional provider to provide those services, and now it's really an integration, and it's bringing everybody to the table that impacts a patient's well-being and care, and the community is very much a part of that.
Yeah. And that's really all we have time for right now, so keep you right there. I want to thank you both for this very interesting thing, because this really is, I don't think folks at home may realize how transformational this time is in healthcare. Mm-hmm. And the finances are going to drive it, but not necessarily in a bad direction, because we're able to have data now that allows us to know how good a job we're doing.
Thank you so much.
I'd like to thank Dr. Robert Carr and Rowena Bergmans for joining us today and for that tremendously informative discussion.
Thank you.
Thank you very much.
We'll see you next time on Health Talk.
Be well.